Welcome, 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 everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. If you're new to Care Patrol, we are aging care advisors who assist clients and families in finding the right provider of care, the right level of care, oftentimes with us, the right community placement. And we're paid by those providers who offer community placement. That's how we're paid, so that our services remain at no charge to our clients and families and prospective patients and residents, just as these CEUs are at no charge to you. And we do these to give back and to educate, and that's sort of what we're focused on. We're accredited by the Board of Nursing in Alabama, and we're reapplying for accreditation by the Board of Social Work. And for those boards and those, uh, two disciplines, this would be considered a clinical hour. It's 1.0 contact hour. And in order to get the certificate, if you're new to us, in order to get the certificate, or if you're watching on YouTube, you must go to this link, which is password protected. We give the password at the end today, thus ensuring to the Board of Social Work that this is in fact a live or classroom type hour for you social workers. The link I'll read out for you. Some of you I know are maybe not able to see your screen. You're working, or you're eating lunch, or you're driving and listening on your phone. If you're able safely to write this down, please do so. The link is https:// www dot surveymonkey.com. Oh my, I've lost it, y'all. Excuse me. /lowercase r/ numbers and letters, all caps, 97WR B as in boy, R2. We give the password at the end. I've posted this into the chat room for you. And so it should be appearing now. We do encourage discussion. If you're new to, I'm sorry, I'm trying to do something and I can't do two things at once. If you're new to Zoom and you want to add into the discussion, I know Dr. Sipma would appreciate it. We always appreciate hearing your voice in tandem with our speaker. I know we're all enriched when you add your observations and outcomes and experience. If you're new to Zoom, move your cursor to the top of your screen or the bottom, and a bar will appear with the word chat. And join us there and share your opinions with us. If there are no more, there is no more housekeeping, and I'll turn it over now to our speaker, Dr. Rebeka Sipma, who's been so good to speak for us often on areas within her purview, and we're happy to have you back today, Dr. Sipma.
Thank you for having me back. Always happy to talk a little bit about neurology. So for those of you who don't know me, I'm Rebeka Sipma. I'm a assistant professor at UAB, and I work primarily in movement disorders, but also do general neurology with the resident side of training. And today we'll be talking about an overview of epilepsy. So some of those objectives we'll be going over. So first, some definitions, right? What's a seizure versus what is epilepsy? We'll talk about the causes of both of those, as well as some overviews of the medications, as well as the surgical options your patients might be either on or considering. And then discussing why multidisciplinary care is important for people with epilepsy, kind of going over a little bit more on the social work side of there as well. No disclosures in particular for this talk. I have some studies funded by those listed companies here, but those are all in movement disorders and don't have any bearing on today's talk. And again, today's talk is educational, so it's not meant to be medical management for you or for any other individual. You should be reviewing those with your own medical team in particular. All right, so seizures versus epilepsy. So a seizure is going to be just a sudden burst of abnormal and excessive electrical activity within the brain. Where this activity is happening will have a little bit different presentation, right? So you may have loss of awareness, or you may have some retained awareness to some degree, depending on which area it's affected. You may have involuntary movements, abnormal sensations, different emotions, or some stereotyped behaviors. And then epilepsy is going to be a chronic condition where we have some sort of brain disorder just characterized by these recurrent unprovoked seizures, meaning patients are high likelihood of having additional bursts of this abnormal electrical activity. Again, we'll get into some of those causes here later, but we want to address that because left untreated, we can have higher risk of further brain damage, morbidity, mortality, other comorbidities associated with it. And then status epilepticus, we won't dive in too much here today, but just so you're aware of it, is going to be a seizure that's lasting for longer than 5 minutes. Or if we have two seizures where we aren't returning back to baseline, they're not regaining consciousness and back to normal in between those two events. Again, this is an emergency because prolonged seizure activity, this abnormal firing, can wear out the brain, can cause permanent brain damage or even death if left untreated. So a little bit more on types of seizures. So the main ways we divide it are going to be either generalized versus focal. So generalized is going to be the electrical activity is affecting the whole brain. The typical ones we think of here are going to be absence seizures, which are kind of more of our just staring off, unresponsive to what's going on around us. Atonic seizures, where we have loss of muscle tone, where they're more likely to just fall completely. And then tonic-clonic seizures are the ones most people think of when we're talking about seizures. So that tonic is like the stiffening portion, and the clonic is a rhythmic jerking movement. And that would be both arms, legs, everything kind of jerking in rhythm, various stereotypes. And then a focal seizure is going to be one that starts in one specific spot. Now, focal seizure may go on to generalize, meaning it starts in one of these lobes, but then it starts spreading to the rest of the nearby structures and across the brain, and we lose awareness and have more of that going into a tonic-clonic seizure. But we're mostly concerned with how it starts. If it's not in an area that affects consciousness, then we may have preserved awareness during a focal seizure, which we would not expect if it is generalized where all the parts of the brain are abnormally firing. Some of our most common ones are going to be temporal lobe seizures. So that's kind of this area in green on the map. So those are areas where we have the hippocampus, which is involved in memory. Oftentimes patients might have a little bit of a prodrome or an aura before the onset of the seizure. This might be more of a panicked feeling, odd sensations, odd smells, kind of before it starts moving into a motor where we have kind of maybe starting with one hand, and then it marches up the rest of the arm before potentially spreading to involving the whole body. Frontal lobe is going to be this area in blue. This is an area typically associated with your executive function, your personality controls. Oftentimes our frontal lobe seizures tend to come more frequently out of sleep. And then they can have very weird behaviors associated with them of person wakes up, starts hitting the pillow on the bed, and like about the same time when these happen, very exact same thing that happens with it. They're not aware of what's going on. They don't remember the event, but it's always the same sort of thing happening. There are some cases which run in families and like an autosomal dominant behavior pattern. So some people might have a history of that in particular. Other common reasons why we have frontal or temporal ones are going to be if we have trauma because of the traumatic brain injuries. Those are the areas closest to a lot of those bones where you might have some shearing, some injuries, which then lead to scarring in the brain. Occipital lobe is going to be more in this posterior area, that pink area on the right-hand side. And occipital lobe controls our vision inputs and awareness, as well as some reading and some other factors when we're functioning normally. So some patients with these types of seizures might have, again, very stereotyped, consistent change in their vision before either an atonic seizure or some other type of generalization process. If there's an area here that's abnormal, and we're more likely to have some of the photosensitivity. You have all those warnings of, about flashing lights. Careful if you have epilepsy. Not everyone with epilepsy is going to be photosensitive, but again, if it's more this occipital lobe, that might be one who is a little more sensitive to those flashing lights. And then the parietal lobe as well tends to have more, again, sensory areas and motor areas, and can have different types of seizures associated with that one as well. And how we diagnose a seizure, ideally, we'd love to have the demonstration of this synchronous excessive electrical activity. So how we look at that is an electroencephalogram and an EEG. So you have electrodes that are placed at certain spots measured across the skull, and then we're picking up the electrical activity through that skull. A seizure is going to be, again, kind of starting in one area, spread. It's a very rhythmic pattern with a spike and a wave pattern to it on these electrode recordings. Again, that helps us localize as to maybe where it's starting from, where it's going, or are there patterns where it's all over, it's a generalized, it's one of our kind of known generalized epilepsy disorders, so a certain type of pattern to it. We spend a lot of time in residency going through how to learn to read these, interpret these, and what's artifact versus normal. We're not going to get into all of that today, but just giving you an idea of this is ideally how we look at these to confirm them or capture them. In between seizures, people are going to look and act normal. Their brainwaves may not show any potentials of like discharges. So this is most useful when they're actually having an event. In between, it might still just look normal. And a little bit briefly on what to do during a seizure, because if you've not had seizures or known someone, there's a likelihood that you're going to run into a situation where you might be the one responding to somebody who's having a seizure. They can be very, very scary. So I want to take away some of that, I don't know what to do, and give you a little bit of those skills here. So first thing is just going to be making sure they're safe, right? If they're kind of maybe out of it, they're going to maybe start losing consciousness. Let's get to them lying down, making sure their head doesn't hit the floor and cause a concussion or some other injury. Are we in a situation where it's going to be safe to stay here versus do we have to like move slightly, right? If we walking in a parking lot where cars are going to be driving by and we need to get to a space where more people can like make sure it's a little bit more cordoned off and safe. And then big thing too with safety is going to be turning them onto their side and letting gravity keep that airway open. There's usually myths about, swallowing your tongue and things like that. You can't physically swallow the tongue, but you may bite it. And if we're just on our back, that tongue may move into a spot where you aren't getting air through that airway like we need to. Same if we're drooling or if we're vomiting at all during this, we don't want those secretions going back into the airway. We want to turn onto our side, face down or towards the side, so that way gravity is going to pull out any of that saliva, any vomit, pull that tongue forward, so that way we're able to keep breathing, keep safe during this. If possible, timing how long it lasts can be very helpful. And then two, when you get to the hospital or you're talking with a doctor, we're going to be asking what happened. Can you describe what was moving, how it was moving? That's useful for kind of us trying to figure out what was going on, or if it's something that looks like a seizure but wasn't a seizure. Now that we've got phones with cameras, sometimes too, that can be helpful of just getting a quick video of what were the eyes, arms, legs doing during that time. Not uncommon for patients in a seizure to bite the side of their tongue because they're not aware of what's going on, or losing their control of bowel bladder during an event as well. And then again, calling EMS, right? If this is lasting several minutes, we're going to probably need a medication to stop it. And then they want to get evaluated, making sure we don't have any lacerations, didn't hit our head, and then talking about kind of what was the cause of this. If, again, patients are known to have epilepsy, they miss the dose, they know exactly what happened, and we don't need to full on go to the hospital, but most of the time it's going to be going to the hospital to get some labs, get some imaging, double check that we're on the right dosing of everything and don't need to adjust any medication. And then seizure precautions afterwards, right? So if we've had a loss of consciousness event, we are not supposed to be driving, and most states for at least 6 months. Every state's a little bit different on how they process that. So California, where I practiced previously, we had to fill out forms, and then they would have to get documentation from their doctor after 6 months that we've not had repeat loss of consciousness events. Alabama doesn't have as much of that documentation, but again, we're not supposed to be driving for 6 months after an event like this. And then cautioning too of like being aware of our surroundings, right? If we have epilepsy where we're at risk of having another seizure, are we going to be in situations where that loss of consciousness could be very dangerous or life-threatening, right? So if we're in an area where we're swimming alone, bathing alone, where even a little bit of water in the wrong positioning can block that airway and be at risk of drowning, that can be a threat to life or further brain damage. Same with like working on ladders, roofs, or higher up places, or if we're using like power tools, dangerous equipment. If we lose consciousness and awareness, is that going to put us at risk for death or injury? So trying to be aware of places at home, places at work that might be problematic, right? Are there sharp things? Are there rugs that we can slip on, or other things that are going to be not ideal for if we do have repeated events? And a big reason why we want to treat these too is going to be SUDEP, right? So that's sudden unexplained death in epilepsy can affect 1 in 1,000 adults with epilepsy every single year. And this is most commonly with our generalized tonic-clonic seizures that are coming out of sleep at night when people aren't observed and don't have someone helping them to make sure that airway is not obstructed by a pillow or blanket or just their positioning. And right, so that's a fairly high number, and we really don't want any of our patients to have to go through that and their families be subjected to that as well. So a little bit more on provoking factors and some of the underlying causes. So there's, first off, right, are we dealing with a seizure, or is this a seizure mimic? You can have convulsive syncope is the most common thing that gets confused for a seizure. So that's we have decreased blood flow to the brain, whether it's a cardiac abnormality or a vasovagal event or some other reason where the heart's just not pumping enough blood. We are then dropping in order to try and restore that blood flow to the brain. And in the process of trying to come back to, we have some twitching, some jerking, some other abnormal movements. You can look up back in the day, before it was probably considered unethical, they did tests on German medical students for convulsive syncope, like forcing them into syncope and then taking videos of what happened during those events, and they can look very similar to seizures. So oftentimes syncope will have maybe some more prodrome of I feel lightheaded, I was sweaty, and some autonomic dysfunction before the event happened. Non-epileptic spells also fairly common. They can co-occur with people who have epileptic seizures. So these are going to be kind of the body is shutting down in some way, shape, or form. So our fight or flight response and dissociation responses are part of the brain in order to protect the body, help with our survival instincts, right? But people who are have gone through a lot of trauma, have other undiagnosed pain, mood disorders, those sorts of things, their brain is living at a very, very high level of stress constantly. And additional things that kind of push them over that threshold can result in their body shutting down where they don't have full control over what's going on. These patients frequently, though, will be aware of what's going on. I can feel my body moving. I can hear people talking to me. I just can't control things. So these ones can be hard to diagnose with or convince some of the patients that this is what's going on without the EEG. So that's sometimes where the epilepsy monitoring unit can parse out which cells are epileptic versus non-epileptic. But again, retained awareness when there's whole body movements can be a sign that this is not a seizure going on. And again, certain movements, so like hip thrusting or kind of irregular movements, right? So seizures to be rhythmic and stereotyped. If this is highly variable, not the same throughout, it's less likely to be abnormal electrical activity that's causing it and more of a non-epileptic spell. With migraines, some auras with migraines can be, we have loss of sensation or loss of control of one side of the body, can present with a couple different things, and then a headache, either with it or right afterwards. Transient ischemic attacks are, again, decreased blood flow to the brain due to a clot where we have decreased sensation, potentially a loss of awareness depending on where that blood clot is. Movement disorders, so things like tics and myoclonus also can be fairly stereotyped and repetitive, but they're not associated with abnormal electrical activity in the brain that's going on and are treated a little bit differently. And then two, we talked a little bit about those frontal lobe seizures tend to come out of sleep and have weird behaviors associated with them, but are stereotypes. Whereas like REM sleep behavior disorder or periodic limb movements in sleep are a separate sleep disorder where it's not this electrical activity that's abnormal. So sleep studies can help sometimes distinguish between epilepsy versus these other sleep disorders with weird movements. And then in kids too, oftentimes breath holding spells and then reflux can cause some like crunching sort of movements. Those can look similar to seizures with involuntary movements. So getting back to seizures, right? So what are some triggers or provoking reasons why someone might have an isolated seizure or an event? Alcohol intoxication or withdrawal tends to be our most common sort of trigger or provoking factor. So in anyone who's had a prior seizure, we really recommend against any amount of alcohol just to prevent that brain from continuing to have this electrical activity abnormalities. Same with illicit drugs. Other toxins like heavy metals can build up and cause brain dysfunction. Certain medications, so there's antibiotics in the hospital we know are going to lower our seizure thresholds, meaning we're more likely to kind of tip over that line into having a seizure. Certain antipsychotics as well, so Wellbutrin at very high doses was one of the ones we're concerned about. And then two, if they're on a seizure medication, if we miss a dose or multiple doses of that medication, then that can bring out another seizure just from that rapid withdrawal of that medication, which is otherwise kind of keeping our brain at a more stable, less irritable, less likely to go into that electrical activity changes. Same with sleep deprivation, right? So we know the brain does not function well with sleep deprivation, and someone who has a predisposition or kind of a lower threshold for going in to have a seizure, sleep deprivation might provoke one. And then kind of what's going on in the rest of our system. If the sugars are too high or too low, that can bring out electrical dysfunction because the brain is very dependent on the glucose for its ability to function. Same with electrolyte abnormalities. So sodium, if it's way too high, way too low, is a particular one because sodium is very involved in our neuron communication and transmission. There's also increased reports of like a B6 deficiency, and people with Parkinson's can cause some seizures here as well. It's fairly rare, but again, different types of electrolytes are going to be part of our typical workup when someone coming in with a seizure. And then infections, whether systemic or intracranial, so like a meningitis, encephalitis, too. Again, we just have irritability. The brain's not functioning quite as well as it should be normally. Head injury or bleeding, blood in particular is very irritating to the meninges, which causes pain, and then the cortex, which can cause this abnormal firing. So if someone's had a traumatic brain injury and or just a bleed from any other reason, then that can predispose to a seizure here or there, and we might keep them on seizure medications while that's resolving. Flashing lights can be a trigger for certain types of epilepsy, but like I said, you need kind of that predisposition. It's not going to just provoke it in anybody who's coming across those flashing lights. And then reasons for epilepsy, right? Why might we have recurrent or this predisposition to seizures without any other provoking factors? So there's a number of different genetic types where we have a gene affecting how these neurons are firing or how they kind of recuperate from firing and can be predisposed to having spontaneous abnormal developments of these seizures. Sometimes too, as the brain is developing in utero, there's a very important process of they'll start in one spot and then they migrate to where they're supposed to be long term and grow into the neurons that they're supposed to be. Sometimes, for various reasons, we have trouble with that migration, trouble with that brain development. And so, especially for childhood onset, we're looking for, do we have any of those predisposing abnormalities as just to how the brain formed in and of itself. Like I said, traumatic brain injury too can cause scarring, especially to these frontal parts of the brain where it's close to a bunch of sharp bone, as well as the temporal lobe in the brain, which is close to, again, the base of the skull. Strokes or vascular malformations where we have some scarring in the cortex or some bleeding that's abnormal and causing irritation. Can be a nidus or an area where it starts being irritable around there and then can spread. Tumors, especially in our older adults, if someone's coming in with a new onset of seizures, we want to look for strokes as well as tumors, infections like meningitis, encephalitis, tuberculosis, things that have caused scarring along the brain in one form or another, then can predispose to having recurrent problems coming from there. Our autoimmune disorders as well, so we can have autoimmune encephalitis. So there's antibodies which are attacking parts of the brain, causing inflammation and causing dysfunction within there. As well as neurodegenerative diseases, so things like Alzheimer's, as those cells in the brain are dying off, then they're not functioning like they should be, right? And so part of not functioning might be going on to develop abnormal electrical activity, including some seizures. And then there's a number of times where we just cannot figure out why they've got epilepsy, but we know that it keeps coming, and so we're going to still treat them with the medications for that. And then management options here. So first, it might just be monitoring, right? If we have a patient coming in with one-time seizure, normal EEG, normal head imaging, normal labs, it might just be you had one seizure, you stressed your brain out to some extent, and likelihood of it coming back still on the fairly low side. So we'll just monitor without any medications. If it is provoked, right, on our lab workup, we figure out you're drinking alcohol and the sugars are way too low and we didn't sleep the night before. Maybe it's just going to be making lifestyle adjustments where we're not doing those sorts of things anymore and avoiding having further seizures. Or are they on a medication that is lowering their seizure threshold, so you just need to come off that medication, and then your brain should be back up to a otherwise normal level of function. And like I mentioned earlier, right, if we have a underlying cause, right, a brain bleed, an infection that we know is likely to cause some additional seizures in the near future, we might start a low dose of a seizure medication to help stabilize. And then as the infection, blood resolves, whatever it is starting to improve, then we can talk about slowly weaning off that medication, as we might not have epilepsy. We might just have had a provoked seizure in those settings. Then medications, we have a lot of different medication options these days, right? So back in the 1800s, early 1900s, we had handful of medications that worked. So most people ended up being on phenobarbital and phenytoin. They worked well, but they had a lot of long-term side effects, are quite sedating. Again, the goal for these is to try to reduce excitability within the brain and trying to reduce the abnormal excitation. You also get some just over sedation of the brain as everything's kind of more muted. Second generation ones, though, we still use a fair amount of carbamazepine, clonazepam, valproic acid, clobazam are frequently used still today. A little bit less in the way of side effects, but can still have a number of different alterations from them. And then these ones tended to be metabolized through the liver as well. And so if you have liver dysfunction, can be fairly problematic. And then during pregnancy, a lot of these first and second generation ones can have effects on a developing embryo and fetus here. And so could have some problems with those ones. 1990s, we got another 7 or 8 new drugs. Levetiracetam and lamotrigine are most commonly used ones now because they're our safest options during pregnancy, and tend to have a little bit less in the way of side effects. Oxcarbazepine is a slightly different formulation compared to carbamazepine, maybe a little bit better tolerated for a number of patients. And then again, topiramate we still use for a number of reasons. And then kind of a similar variant of that is denisomide, which is developed a little bit later with a little less in the way of brain fog and risk for kidney stones that can come with topiramates. And again, 2000s, 2010s, we've had explosion of another different types of seizure medications. Some of these are specifically for unique types of epilepsy or childhood epilepsies, which are fairly refractory to a lot of the other medications that have been developed here previously. Most patients are going to be on a monotherapy, as about 50%, I believe, respond to the first or second drug that they're tried on. Sometimes we'll combine 2 of these depending on, again, how they're tolerating things as well as what their seizure frequency is. Some of the things we consider as doctors when we're making a selection for which medication to start somebody on. First is going to be the type of seizure epilepsy that we're treating. Some of these medications work a little bit better for the focal ones as opposed to the generalized seizures. And then there are certain types of epilepsy, certain genetic reasons where if you use a medication that's just working on certain channels, they already have an abnormality with that channel, we might make things worse, right? So knowing the type of epilepsy we're treating can be useful in trying to figure out which mechanism might be the most one effective and not going to cause things to be worse. Other consideration, right, is going to be, do we have an IV option for this medication or is it only oral, right? Someone who's coming in status epilepticus, not able to swallow, not aware of what's going on. We need something that's going to be able to be infused and going to have a rapid onset of effectiveness for those patients. As well as going with side effects too. Some of these depends on how fast you give them. As to if we're going to have side effects or not. There's some that can have the risk of rash, the lamotrigine in particular. And so if you go up quickly, that rash is more likely versus if we go up slowly, then that's less likely to happen. So inpatient versus outpatient is also a consideration of, do I have a couple weeks to try and get this up slowly, or is this something I need to work right now? As well as metabolism, right? So how is this medication being converted to its active form, or how is it getting out of the body? Usually these are going to be through either liver modification or kidney modification and kidney excretion. And so if they have dysfunction in one of those organs, then it might limit which medication we're picking and how high of a dose we're able to use without causing unwanted side effects. As well as because a lot of these are metabolized through the liver and working with specific enzymes, combining them with other medications may make other meds more or less effective depending on what effect it has on those enzymes. And then are these side effects something that's worth the risk for somebody, right? So like I said, there's only a couple that we know are safe in pregnancy. Some of them, as we infuse them, have a likelihood of causing more abnormal heart rhythms, which can be dangerous and life-threatening for people. Sedation comes with almost every single one of these medications because, like I said, they're working to try and tamp down excitation within the brain. Some people are more sensitive to one versus the other, and as well as how high or low of a dose we're using. Some of them have effect on our platelets or our other blood counts, so someone who already has a problem in that area wouldn't be a good candidate. Some of them work as well for improving mood, and some of them can worsen mood. So taking a psychiatry history as well for your patient can be helpful in determining which option is the best, as well as other neurologic problems, right? So patients may also have migraine headaches. They might also have tremors or some separate myoclonus or neuropathic pain. And some of our seizure medications work better on treating those things as well, right? So some of our topiramate or gabapentins can work well for migraines, tremors. I can use Keppra or zonisamide or levetiracetam or zonisamide. And so kind of if we can treat two things with one med, that's going to reduce our overall pill burden for patients as well. And then long-term effects. Again, more common with our older drugs, right? So those very sedating ones tend to have a little bit more in the risk of osteoporosis because we're leaching some of that calcium from the bones, which isn't great. And some of them also can affect the cerebellum. So you get more of the imbalanced long-term coordination problems with prolonged use for those older first-generation medications. As well as, right, cost and accessibility. If I send this patient out of the hospital after they had several seizures, then they can't afford that medication or their pharmacy doesn't have it in stock, they stop taking it, then we're going to be back in the hospital with complications or at risk of morbidity and mortality as well. And some of these are going to have to be monitored a little bit more closely, right? If we know we're going to be at risk for blood count abnormalities or a heart rhythm problem, which labs or EKGs or other things do we need to make sure they're following up on, versus if I know this one's maybe not going to follow up as consistently, is there something that's a little safer to send them out with that won't require as much monitoring? And then if we aren't responding to the oral medications, if we've tried 2-3 doses of different meds, then we start talking about what are our more invasive but potentially more long-term ways to stop these seizures from happening again. First, we're going to start with brain mapping, right? We want to know where these seizures are coming from as accurately as possible. So the surgeons and the epileptologists are going to open up the skull and put sheets of surface electrodes on where they can record the activity within the brain. And then they'll use some deep electrodes as well, because not everything is coming from those surface where those electrodes are. We want to get closer to that site where things potentially are stemming from. Um, as well as then we'll use some stimulation. We'll have the patient awake with the brain open and then use stimulation to figure out where are the language areas, which areas have movement, sensation, vision that are near the site that we're potentially going to be either taking out or modifying in some way. If we have an isolated seizure focus and nothing else that's super active in the rest of our coordination with other day-to-day movements, we might just be able to go in and take it out, versus if it's right up next to that speech center, invasive surgery in that area might be then, we risk not being able to communicate, which might be far worse for those patients. So then resection and ablation, these are kind of the longer standing option things that were tried here first before we get into some of our other techniques we'll talk about next. So focal resection is going to be yes, we've identified that one little spot where this is originating from. We're going to go in, take that one specific spot out, and that is it. A lobe resection is going to be we're taking a much larger section of that out, right? So we're just taking a good chunk of this temporal lobe out or the frontal lobe. A hemispherectomy is going to be in more extreme cases. Sometimes like a child will have infections which affect the whole half of the brain, and then that causes it to fire and continuously have seizures. So they might talk about taking off about half of the brain in some of those extreme cases. A lesionectomy is going to be we have like a tumor or the vascular abnormality or something else that's not brain tissue, but it's causing that irritability, and we want to go in and take that portion of it out. There's also some a little less invasive options now of like laser interstitial thermal therapy. We're not cutting open the brain, skull is still closed, but we're using a laser to go in and burn that area where that lesion is coming from. Same with stereotactic radiosurgery skull stays closed, but we're using radiation to direct it to that very specific spot to kill off those cells that are causing the problem with the misfiring. And corpus callosotomy is another less commonly used one now. It was used a little bit more commonly in like the 80s, 90s, earlier 2000s. The corpus callosum is a white matter tract which connects the two halves of the brain, right? So you have right brain controlling left body, left brain controlling right body, and you have these interconnection fibers between the two. So if you have someone who is having it start on one side and it's spreading fairly quickly to the other side, trying to cut that connection in between those two halves might help reduce some of the spread and the frequency in which they're having those generalized seizures. And then neurostimulation. So this is going to be, we can't take out that spot. Maybe it's too close to some of our other vital control centers, whether for speech or vision or movement or something else. And so we're going to go in and kind of change the electrical field in that area. Back in the 1950s, they had figured out that if we see that there's a seizure ongoing, we provide some electrical stimulation that can short circuit it and kind of get us out of that abnormal pattern. So there's various ways in which we've learned to do that over the years. First one that was approved is the vagal nerve stimulator. So that's the first top right one here. We've got a little bit of a battery pack that sits underneath the skin in the chest, and then it connects to the vagal nerve, which is one of the nerves that's coming down from the brain to the stomach, the diaphragm area. And it's sending signals of electrical stimulation just at a kind of steady pattern based on however the neurologist sets the settings for. And then some people, as they get an aura or sensation of their focal onset seizure, you have a magnet which you can push over the stimulator. It'll send more signals then to try and disrupt that start of a seizure that you're maybe feeling. And then more invasive options. The NeuroPace is going to be this one over on the left-hand side. So you have kind of a strip of electrodes or potentially some deep electrodes here. And so you have multiple spots where they're sensing kind of what's going on, and then it can provide stimulation to those areas when it's detecting abnormalities. Deep brain stimulation is going to be, we put these single leads down into the deep parts of the brain, targeting the anterior part of the thalamus. Thalamus is kind of a main circuit board of interconnections between lots of areas of the brain. And I found that anterior thalamus in particular stimulation there can, again, help disrupt some of those seizure frequencies and help control our seizures a little bit better. Both of those tend to work a little bit better for our focal seizures if it's not a whole brain activation. It's starting in one spot and getting communicated through the rest of the brain. And so we can kind of target where it's starting or kind of target that spread as opposed to a generalized where it's starting everywhere. It's hard then for a stimulation in one spot to change that diffuse kind of electrical stimulation or electrical abnormalities. And then getting into a little bit more on multidisciplinary care here as well. So big thing here, social work, right? So this is a life-changing diagnosis for a lot of people, comes with a lot of implications for them, right? So there's financial burden of hospitalizations, the medication copays that they're going to be on long-term here as well. This can be very disruptive where they're losing work or interruption of their education, or they may not be able to go on and finish the degree they were anticipating or have the job that they were anticipating. Or maybe needing to change vocations, right? If this is someone who's a roofer and is having uncontrolled epilepsy where they're losing consciousness frequently, fall from high up would be potentially catastrophic for them, right? And so can be very disconcerting when they're having to miss work or kind of change something that they've been accustomed to doing here as well. Again, with that, having to wait 6 months before driving themselves again, transportation problems can be very problematic, especially in areas where we don't have a whole lot of public transportation, right? So some of these remote areas, that's not going to be an option. And then as well, this is going to be a working with the system and resource navigation. If we're having these recurrent seizures where we need to stay in the hospital for some of that brain mapping, getting all of that figured out, that's going to require insurance approval. That's going to require coordination with your admission team and doctors. And for people who already have some brain dysfunction, that's going to be a little bit more of a challenging process for them to independently navigate. They're going to need to have someone who's familiar with the ins and outs, helping kind of direct them, as well as, again, resource navigation, right? Are they deemed temporary disability? Are we at a point where we need long-term disability because we can't get things under control? Do they need other methods of transportation or genetic counseling if we are dealing with a genetic epilepsy, kind of identifying what those needs are and being able to connect people there. Identifying other barriers and crisis intervention. We'll talk a little bit more about mood here in a second, but patients with epilepsy have a much higher risk of depression, anxiety, suicidal ideations, partially because of the brain dysfunction, right? The neurons just aren't firing quite as well. Some of it might be medication induced, right? We're taking meds which are disrupting some of that transmission within the brain, or adapting to a new diagnosis, which they weren't necessarily prepared for. Other parts here too that as physicians we don't always initially pick up on or may not fully identify right off the bat too can be cultural differences or educational kind of limitations as to what they're understanding. The Spirit Catches You and You Fall Down is a book we had to read in medical school about a Hmong family in California who was trying to treat the epilepsy using their kind of more traditional methods of healing and not buying into the medical diagnosis and needing the medications, and how do those cultural differences and misunderstandings lead to harm for patients or other problems that are arising as well. So having social workers who are a bit more adept at identifying some of those things can be helpful as like keying in the rest of your providing team to like, hey, I think they still have these questions or these concerns or wanted to ask more about these other, different understandings of it. Or I think I had a social worker when I was in Kenya as well, being like, a seizure is less of a scary diagnosis versus like epilepsy. Of like a seizure disorder seems like more normal, but there's more stigma with an epilepsy diagnosis. And so knowing the people, knowing the ones you're working with, asking some of those other in-depth questions can be quite useful, but again, honestly, don't always have time for in the clinic setting or the hospital setting. You guys are very adept at doing that. Again, you're a person of trust, right? They understand that you're on their side. You're trying to help them. You can help with some of the education, connecting with support groups, other ways that help round out their support system and help them live as normal a life as possible, right? With medications, with potentially these surgical options, we can get people living a fairly normal life. And so we want to encourage them to work as best they can and have a fulfilling life, continue the hobbies that they enjoy as long as, it's within reason and safe for them. And then
What was the
psychiatric,
name of the book? I'm sorry to interrupt. Someone asked for the name of the book you
yeah,
referenced.
it was The Spirit Catches You and You Fall Down, I believe. I'm trying to remember off the top of my head. It's been like 10 years now since I've read it, but
Okay,
I can always Google that and send it later, but I'm pretty sure it's The Spirit Catches You and You Fall Down.
thank you.
Yeah. And then psychiatric care. So, like I was mentioning a little bit here earlier, of high odds of developing depression, anxiety, suicidal attempts. And then insurance coverage for psychiatric care is highly variable, right? So, do we need to talk with the patient about like we need a different insurance, or we need to find some of these low cost resources for you to have access to these? Because that's going to worsen our ability to continue taking medications, our ability to follow up with the doctors that we need to see. And then also kind of touching back on these non-epileptic seizures or functional neurologic disorders can co-occur with epilepsy, right? So because of the stress of the chronic disease, as well as the depression or pain or some of these other things going on, potentially trauma tends to be a trigger as well, whether sexual abuse or verbal trauma or other things kind of in their life, putting stress on this brain where we're constantly in this fight or flight mode. And we need to then work not on just adding more medications, because the meds aren't going to work on retraining the brain and getting out of that trauma response. It's going to be cognitive behavioral therapy, working with psychiatry, helping patients understand what's going wrong with the brain in a different way. So some of the other books I mentioned here that can be very helpful for patients as well as providers. So What Happened to You by Dr. Bruce Perry does a good job of kind of explaining how childhood trauma affects brain development and ability to cope with stress, and some of the things that can help calm down that fight or flight response. The Body Keeps the Score by Dr. Evander Kolk is another one that was published a little bit earlier that goes through some of these things. The Functional Neurologic Disorders Hope website, fndhope.org, also has a lot of good resources for helping patients kind of understand, realize they're not alone in doing this. And again, these are not stemming from we've got a tumor or a stroke or something structural causing the problem, but it is the brain is rewired in response to this high level long-term stress. And so it's not going to be an immediate, I know what's happening, everything is fixed back to normal. It's going to be we do have to work to retrain the brain. It is treatable, but it takes a lot of work and effort, and recognizing what are my psychological triggers? What are the things that are contributing to my body shutting down in this way? Again, there's lots of different names for it. There's non-epileptic seizures, non-epileptic spells, psychogenic or functional. We tend to stay away from psychogenic because of the stigma being like, people are like, oh, you're just saying it's all in my head. There's nothing you can do. And it's not that it's, nothing we can do about it. It is coming from your head, but it's in a different way than we would, typically think about psychogenic. It's not that you're crazy. There is physical like rewiring in some ways. There's functional changes, but it's not that you're just crazy and we're brushing it off, but it is we need to address the level of stress and the homeostasis responses to all of that. And then dietitians, another very useful part of our multidisciplinary teams, right? So the medications that we're trying, some can cause weight gain, some cause weight loss, and related to nausea, GI upset with some of these medications, as well as some of them, again, affect how we're absorbing vitamins and minerals. And so having a knowledgeable dietitian can be helpful in maintaining our weight. The other big part of it too is, as particularly with kids, it's all weight-based, as well as adults too. We want to make sure we're on a dose that's appropriate for their weight. If we're giving too little of the medication and it's just getting absorbed into a lot of the fat or into the muscle and getting used up, then we're not getting the amount that we need into the brain where it needs to be working. As well as ketogenic diet is not recommended for everybody. It is very difficult to maintain ketosis where you are just running based off of these ketones instead of blood sugar or the glucose that the brain normally functions on. So it's hard to get into ketosis. It would require a dietitian to work with family, in particular for like kids with some of these specific childhood epilepsies are usually the ones where we're mostly going to be dependent on that. But figuring out, okay, what foods have sugars in them that we're trying to avoid, how to eat a lot higher of a protein diet without causing other complications as well, right? And then pharmacists, very valuable here as well, right? So like I said, we have a number of different medications. To remember every single side effect from every single one of those is quite difficult. So having someone who's a little bit more versed in that can be very useful, as well as which things are interacting with what, right? There's more and more drugs getting developed by every group these days. And so I will not necessarily know or be aware of all of those new drugs and those potential interactions. So pharmacists can flag things, ask questions, help us with making sure we're making the best decisions for our patients, as well as, again, reviewing labs, making sure that if we're drawing levels to try and measure the amount of drug in someone's system, timing is very important, right? If we measured at the end of the dose, this is going to be where are they at the very bottom of that dosing? If we're measuring a couple hours later, it might be, peak dosing. And so what looks too high or too low is going to be very dependent on timing of the medication administration as well. As well as insurance barriers, right? A lot of hurdles for getting newer medications, which are often still times name brand, not generics, and getting those approved for coverage can be a labor-intensive process. So having, again, someone who's familiar with that might help out with that at certain institutions can be very, very helpful. And then as well as, again, making sure patients understand, right? Is this a medication that we just take once a day, 3 times a day? Do we take it with food, without food? It can be a little overwhelming for patients to just hear it briefly once. Having multiple points where that's kind of reiterated or someone they can ask questions of is also very helpful in keeping those meds consistent for them. Or again, having someone they know to reach out to, like, I'm having this problem with it, how do I troubleshoot? Do I need to come off this or switch it? Or it's something that'll go away with just staying on the medication for a little bit longer. All right, so a lot of information, brief summary here, make sure we are on the same page, right? So epilepsy means the patient's likely to have recurrent abnormal electrical activity or seizures in the brain, which is kind of a higher risk for injury, comorbidities, and death, which is why we want to make sure it's treated well. Again, there are certain provoking factors: alcohol, drugs, medication, sleep deprivation, changes to our electrolytes and blood sugars, infections, inflammation. And epilepsy, where it's that chronic recurrence, might be secondary to genetics, the way our brain developed initially in the womb, or other things that have caused scarring, inflammation, other dysfunction within the brain, which is going to be there for the rest of our life, and therefore it's going to continue to put us at risk for more of this misfiring. But we've got a wide variety of medications available, as well as several surgical options and lesional therapies available for patients who aren't responding ideally to those medications. And really, these patients do best when we have multidisciplinary care, right? Including social workers, pharmacists, psychologists, dietitians, and other parts of the team where they can feel connected, feel like their questions are answered, and they're able to maintain as normal a life as possible despite these bouts of abnormal electrical activity happening. And some other resources for you guys: Epilepsy Foundation, Epilepsy Alliance of America are great in regards to, again, digestible information, other resources. These next two, again, helpful for those patients who are also dealing with those non-epileptic seizures, those other events, which are also very disabling. And then a couple other ones down here too for some of the other more rare causes, or if you're trying to connect patients with a epilepsy center that can provide more of that comprehensive care for them. Any questions?
I haven't seen any questions come up yet. I'll read the link again while people are thinking of their questions. The link today, whether you're live or on YouTube, is https://www.surveymonkey.com/lowercase r/letters and numbers 97 W R B as in boy, R2, and the password is people with a capital P, as in a multidisciplinary team is comprised of many people, and the people that we're caring for are people with a capital People. I've posted this in the chat room. I'm not seeing any other questions come up.
And
It was a lot of information. Thank you so much for taking us through that.
I did confirm that book is The Spirit Catches You and You Fall Down by Anne Sadaman.
And
So,
someone in our chat room also answered that they had read it and found it very interesting.
yeah.
So I know as social workers, folks always appreciate resources, particularly those that are in
Mm,
case management. So thank you for thinking of us
yes.
and providing those books and opportunities to learn further. And thank you for all that you do for us. Thank you to those of you who are on the line on Tuesday, the 19th. We will have Dr. K. Nicole Brown, who will teach us on anything new that's come up with the DSMV. So please be sure to join us there. And one person did ask Dr. Sipma if you could go back and retouch on the resources at the end again.
So, Epilepsy Foundation and Epilepsy Alliance of America, great educational resources for you guys, for patients, kind of breaks down a lot of the medication, surgeries, other common questions. The non-epilepticseizures.com and fndhope.org are going to be very useful for your patients who are dealing with these non-epileptic spells where it's not electrical activity, but it is the body shutting down or panicking in some other sort of way, showing signs of those stressors. And then Rare Epilepsy Network combines, gets access for some of these patients who have specific types of epilepsy, which are a little bit more niche and might respond better to different things. National Association of Epilepsy Centers has a again network of different hospitals. They have some recommendations as to, like, again, these recognized epilepsy centers are going to have the surgical options. They're going to have further diagnostic options, multidisciplinary teams, and also, again, just good information on what is epilepsy, what are some of these things we're reading about, talking about, hearing about, etc. And those
Terrific.
other
Thank you.
books that I had mentioned here were the What Happened to You by Dr. Bruce Perry, and then The Body Keeps the Score by Dr. Vanderkolk.
Thank you so much, Dr.
Yeah.
Sipma, for doing that, for going back through those. Thank you for your time today. We hope to see you all on our next CEU. And remember, these are always available. And thank you, Dr. Sipma, for allowing us to record. These are always available on YouTube. And may we have your presentation to send out with the certificates?
Yes, I will get that to you after I come off of this meeting.
All right, terrific. Well, again, thank you, Dr. Sipma, and thank you for everyone on the line. I hope you have a great couple of weeks and join us again on the 19th with Dr. Brown and the DSMV. Y'all take care.